So I'm going to welcome everybody. And how is everybody? Would love to see you wave and give us the thumbs up. There we go. All right, good job. And that is not a sugar high, right? Okay.
No.
It's so wonderful to see new faces. It's so wonderful to see familiar faces. Some of you have said, sign me up for every coffee. Just send me the link right before. So that's great that you're a loyal learner, always wanting to learn new things. So thank you for joining us today about the diabetes presentation. And I think everybody can hear me. We've kind of got through that. We've talked about your goodie bags that were the healthy, low carb, low sugar snacks. You have a paddle. And hopefully you also have the book, The Bittersweetness of Diabetes, My Personal Journey by Cheryl Crane. And actually Cheryl, amazing as she is, she wrote this book and she is the author of the book and she is joining us today. We're honored, Cheryl, that you joined us. Can you give a wave so everybody can see you, Cheryl? There she is. Would you like to unmute and maybe say a word or two?
Muted? Okay, you can't hear me?
Yes, we can hear you.
You can hear me?
Yes, we can hear you.
Okay, yeah. No, I'm just saying hi, and I'm glad to be part of this. Anytime you can learn something new, I'm all ears. So.
Oh, great. Well, the book is marvelous, and related to that book, your friend and our friend, Jim Greenwald, is the amazing, I was thinking he was an artist, but Jim, you prefer the word cartoonist? Help me with that. Which is your preference, Jim?
Oh, definitely cartoonist, because I go into an art gallery and if I say I'm a cartoonist, they're always afraid the roof is going to come in. So, yeah. Hi, Cheryl.
Hello, Jim.
Well, many thanks to you both for your work on this very important topic and for donating these books so that our guests today can have them. Jim did the illustrations in the book, and he's done other illustrations for us. And it's almost like a glamour shot. He certainly makes us look better in cartooning than we do in real life. So Jim, thank you for that. Before we begin, just a couple of housekeeping things. Joyce and Claudia kind of drive here today. So they'll be sure that you're muted so we don't have feedback. But if you have a question as we go through our presentation, just wave to us or give us a thumbs up or something and we can pause for a moment to ask the question. And we encourage you to ask these questions because it really does create a great conversation. And Dr. Hanna Moussa is so bright and so willing to give us his time this morning to talk about this very important topic. So as we hear the questions, as we hear his presentations, and he's going to do a little true and false kind of thing as well, we will all learn much, much more. Okay, and again, we all have our paddles, I hope. And so be sure to raise those when he does the Q&A kinds of things so we can see if it's true or false. So these paddles are such a great learning tool for us also. So back to diabetes, you might know that diabetes is the fastest growing disease in the country. I actually didn't know that, but it's the fastest growing disease in the country. And we're going to learn about how to take control of all that, how to manage those things. To help us learn more about managing and preventing diabetes, we are joined today by our special guest, Dr. Hanna Moussa from the Arizona Endocrinology and Diabetes Clinic. And I believe he's here in the West Valley. Are you in Sun City or Sun City West?
In Peoria.
Peoria, okay, just right around the corner, thank you. So a little bit, let me just make sure. Okay, a little bit about Dr. Hanna Moussa. He is board certified in endocrinology, diabetes, and metabolism, and completed his internal medicine residency at Oakwood Hospital in Dearborn, Michigan, and endocrinology fellowship at the University of Missouri, Columbia, Missouri. Dr. Hanna Moussa has been practicing endocrinology since 2009. During his almost 20 years of practice, he's been committed to providing the highest quality of care and patient experience for his patients. He is an active member of the Endocrine Society, the American Association of Clinical Endocrinologists, and the American Thyroid Association. I didn't know we had those associations. That's wonderful. So now it gives me great pleasure to mute myself and to welcome Dr. Hanna Moussa. Thank you for joining us today, Dr. Hanna Moussa. The microphone is all yours.
Thank you. Let me just share my screen with you.
Perfect, thank you.
Can you guys hear me and see the screen? Perfect. So thank you for having me and for this nice introduction. My name is Abdullah Moussa. I was asked to talk to you about diabetes. We'll try to make it interactive. You're more than welcome to stop me at any time and ask any questions. We're going to talk a little bit about diagnosis, a little bit about diet, and most about treatment and new technology. So, as you know, it's the most common chronic disease in the US. It's amazing to know that 1 out of every 10 Americans has diabetes. So almost 34 millions out of the whole population. And pre-diabetes, which is a stage before diabetes, between normal and diabetes, it's even more prevalent, 1 of every 3. So 1/3 of us joining this meeting may have pre-diabetes, which is almost total 88 million. How do we diagnose diabetes in the medical field? We have criteria. If you have a blood sugar fasting, you wake up in the morning after 8 hours of not eating, go to the lab, have a blood sugar, and if it's above 126, usually we repeat it twice, you have diabetes. If you go to the lab at any time, regardless of eating or not eating, and your sugar is above 200 on 2 occasions with some symptoms, mostly frequent urination, frequent or thirst, you have diabetes. If you do what we call the glucose tolerance test, you go to the lab fasting, they give you a nasty tasting drink that I heard, 75 grams of sugar. You wait there 2 hours, then they draw your blood test. And if it's above 200, that's a diagnosis criteria for diabetes. There is a test, blood test called the A1C, which reflects your sugar for 3 months. We'll go over that in more detail later. But if you have this number above 6.5, currently is diabetes. So symptoms, some people have no symptoms at all. Some people feel frequent urination. They feel thirsty because the sugar basically sucks the fluid into the urine. You feel hungry. If you have an ulcer, it's hard to heal. Have frequent infection, weight loss, which can be a sign of uncontrolled diabetes because you lose all the calories in the urine. Dry skin, sleepiness, blurry vision, it's very common symptoms of diabetes. So what are the types that we know about diabetes? We have few. I'm just going to go over a few of them. Type 1, pre-diabetes. Type 2, gestational, which happens with pregnancy. And there is a growing portion of diabetes that's what we call monogenic diabetes, which is a genetic problems in one gene that goes to cause a defect in insulin. It's another name for it is called MODY. It used to be very rare, but now it's becoming more common because we think about it more. Type 1, what happens is it's an autoimmune disease. Usually it happens in young, in babies or young children, but it can happen anytime, even in elderly people. Your body starts attacking your pancreas. It produces antibodies and goes and destroys the pancreas. When it destroys up to 90% of your pancreas, you don't have insulin and your sugars start going up. And unfortunately, the only thing works for type 1 is diabetes. There is one other medication, we'll talk about it later. But because you don't have any insulin, insulin is the life-saving treatment. There is nothing else that can work. Pre-diabetes, as we spoke, it's somewhere between normal and diabetes. And I just put a sensor on myself to see how it works last week. And I discovered that I have pre-diabetes, so I need to watch my diet. So the criteria for pre-diabetes is if you have a fasting sugar between 100 to 125. As we spoke, anything above 126 is diabetes. Anything below 100 is normal. If you do a 2-hour glucose tolerance test, anything above 200 is diabetes. Between 140 to 199, pre-diabetes. Below 140, that's normal. Your sugar can go up after a meal. The A1C between 5.7 to 6.4 is pre-diabetes. Anything above 6.5 is diabetes. Below 5.6 or equal to 5.6, that's normal. Treatment, basically, it's the same for diabetes, diet, exercise, and there are some medications. Type 2, which is almost the majority of the diabetes in the country, almost 90%. It's mostly an insulin-resistant state. If you have a family member with or a relative with type 2 diabetes, you have a higher risk of developing diabetes. If you're part of certain ethnic groups, we'll go over them later, you can have more risk of diabetes. Usually it's slowly, gradually progress from normal to pre-diabetes and diabetes. So it takes years, sometimes 5 to 10 years before it's diagnosed. Same thing, treatment, healthy meal plan, exercise, and medication. We'll go over those in a few slides. So what are the risk factors for type 2, which is the most common? Older age. And I don't know what's older age mean. I just turned 50. Is that older age? I don't know. Obesity, if you're overweight or obese, you have more risk of insulin resistance. As we spoke, family history. If you got pregnant at one point and you had gestational diabetes, that puts you at a higher risk. Almost in the next 10 years, 20% of gestational diabetes, they become diabetic. If you're pre-diabetes, diabetic, and you didn't take care of it, if you don't exercise, stress, emotional, physical, can put you at high risk of developing diabetes. Ethnicity, if you're African American, Native American, Hispanic, Pacific Islanders, those ethnicity has by their genetic component have tendency to develop diabetes. So what is insulin resistance? You have in the blood, insulin goes as if it is the key that goes to the cells and open the door, though the sugar goes into the cell and does not stay in the blood, and the cells uses the sugar. When you have insulin resistant, the key does not work. So you have more sugar in the vessels, and that's why the sugars goes up. This is the first thing I give my diabetic patient when I see them in the office. This is a 5 pounds of fat. When you see it, it can be sometimes scary. I have to admit that I overweight. I have maybe 2 or 3 of those sitting in my belly, more than what I need. And most of us have those. This is what causes diabetes. This cell produces hormones, and those hormones makes you resistant to insulin. So you may have insulin, maybe less, but whatever you have, it doesn't work. And where you have the fat makes the big difference. If you have it in the shape of an apple, which is mostly in our belly, that's the worst. That's the one that can cause diabetes. If you have it in the shape of a pear below the waist, in your buttock area, that doesn't cause much trouble. Why this cause more than this, we really don't know. So as we spoke, type 1, you have no insulin. Type 2, you have resistant to insulin, maybe less. So the pancreas does not produce enough insulin. And your fat cells, your muscles, they are resistant to insulin, so they don't use it as they're supposed to. And the liver can be too generous. What do I mean by that? The liver in general produces sugar throughout the day. Even at night, if I'm sleeping, the liver always produces sugar. But because of insulin resistant, the liver produces more sugar. So you can wake up even if you don't eat with higher numbers. So basically, combination of all those 3 can cause type 2 diabetes. Just to give you a visual idea about the obesity endemic in the US. This is slides from the CDC. We're going to start with 1990. At that time, you can see almost the majority of the states has an obesity rate up to 14%. Fast forward, 91, we have some Midwest state have an obesity range up to 19. More states, more of them, more of them. Now we have some Midwest states up to 20, and almost the majority of the country has a obesity rate up to 14%. Going to go faster. Now we have up to 25%. Some states with an obesity rate, more. Sound like everything starts in the Midwest. Now we have some states up to 30% in 2006. I'm going to skip to 2011, 12, or 13, 14. Now we have some states up to 1/3 of the population are obese. 15, 16, 19, 17, sorry, 19. This is the latest I found. So in 2019, almost 1/3 of the country has an obesity rate more than 35. That can be very scary. I mean, 1/3 of us are obese. That's why diabetes is so prevalent. In Arizona, we have a rate almost up to 1/3. And I'm sure this is going up, but if I remember the last I heard that in children, the obesity rate now is plateauing and it's going down. So diabetes is a progressive disease. Slowly, if you don't take care of your weight, of your diet, things get worse and your pancreas gets tired and your sugars start going up. So that's why it's important to monitor your sugar. How do we monitor the sugar? We have glucometers. There are different brands, whatever your insurance covers. They're all the same. And the newest thing on the market is what we call glucose monitoring system. Those are devices, you put them on your body. It's a small applicator, you click, it sticks to your body. Some of them, this is a Dexcom device. You see the number real time, all the time, whether on your phone, whether on device or on a pump. This is the Guardian from Medtronic. Also, you can see it on a device or in a pump. Those two are real time. You see them all the time. Freestyle is what we call flash sensory. So you don't see it real time. You have to take the reader, scan it over the sensor, and then it tells you the number. The newer version gives you more features of an alarms. If you start going low or high, it gives you an alarm. But you always have to scan to see the number. This is another sensor. It's an implantable one. It's called Eversense. So a small chip. It's a surgical procedure. You put it under the skin and you put a transmitter on top of it, and it lasts for 90 days. So you take your numbers for 90 days. You don't have to change. You don't have to do anything. Whereas those, most of them for 2 weeks, for the freestyle, for 10 days for the Dexcom, I saw, I think also 1 week for the Medtronic. So this is the longest one, but it's an implantable procedure. And it's not very popular because of the surgical need every 3 months to change it. So what are our targets? We have two different societies, the American Diabetes Association and the American Association of Clinical Endocrinologists. They have close targets, not the same. The American Diabetes Association is less strict. Their fasting sugar, 80 to 130. The American Association of Clinical Endocrinologists, 70 to 100. 2 hours after a meal, less than 180. For this association, they are more strict, less than 140. I personally use the American Diabetes Association. So when do we check the sugar? Fasting. You can do it before meals, 2 hours after a meal, at bedtime to make sure that you're not getting low. You can check if you started the new insulin, if you change your medication, if you change your diet to see how the effect of it, if you're exercising to make sure that you're not getting low, you're not getting high, or if you're stressed emotionally, infection, so because it can affect the sugar. We talked about the A1C. This is a blood test that reflects your sugar for 3 months. And we talked about the criteria for diagnosing diabetes. So what is the A1C? It's a hemoglobin. It's a protein that sits in the red cells and takes the oxygen from your lungs to your body. Sugar sticks to the hemoglobin all the time. So if you have less sugar, the A1C will be low. If you have more sugar in the blood, more sugar will stick to the red cells, and you have a higher level of the hemoglobin A1C. And why is it reflecting 30 days? Because the sugar sticks to the red cells for the lifespan of the red cells until the red cells die. And the red cell lifespan is almost 120 days, so 30 days. That's why this number reflects 30 days. What are the criteria for the A1C? Again, for the American Diabetes Association, less than 7 is the target. For the clinical endocrinologist, less than 6.5, and those are personalized. Young, healthy patient, I will aim for 6, even below if we can, without the risk of low sugar. Elderly people with high risk of low sugar or multiple other medical problems, sometimes 8 is okay, because there is no evidence adding it, lowering down to much lower numbers will add any benefit. Though, as I told you, this is a personalized target. Every patient is different. So where is this 7 number comes from? Why we aim 7? Because diabetes on the long term, it can cause complication and what we call microvascular, small vessel problems that can cause retinopathy, damage to your eyes, to your nerves, to your kidneys. And studies show that at the cutoff of 7, the risk goes up. And the risk is continuous. Even if you're below 7, you have a higher risk. Even if you're normal, if you're higher sugar than normal, you have high risk. But the risk goes up at 7. That's why all the recommendations say 7 and above is above our target. We have to bring it back down. So we talked that treatment is diet, activity, and medication. Exercise. Exercise is known to cause many good things to our body, improve insulin sensitivity. Even if you don't lose weight, you use the insulin in a better way. It lowers the blood pressure, the heart rate, the cholesterol, the stress, the sleep, the blood flow, makes you feel better, increase your muscles. The recommendations is 150 minutes a week, so half an hour, 5 days a week. Sometimes I personally can't achieve this. So it's try to do whatever you can. Always ask your doctor to see if you're okay to exercise, if you have any heart problems or risk of falls or complications, diabetes, neuropathy that can put you at risk of falls. Just check with your doctor. What kind? Whatever you want, whatever you enjoy, whatever you can fit in your schedule, fits your budget, and always know your limitation. You don't need to run a marathon. You just take a walk, 10 minutes. There are some steps that can help. You can use a pedometer. If you achieve 2,000 steps a day, that's almost 1 mile. Take the stairs if you have a place with the stairs instead of taking the escalator. Park far away in the grocery store. Take that parking lot and walk your dog, your kids. Stretch. If you are working in a station or a desk, have a stand-up desk or just stretch every now and then. So there is a program or a study called the Diabetes Prevention Program. It's an old program. They took pre-diabetic. So patient that they don't have diabetes, they have something before diabetes. And they assign them to either lifestyle change, diet, activity, they had a personal coach and meetings, or they assigned them to take a medication for diabetes called Metformin. It's an insulin sensitizer. And after a year, the first group was able to lose 7% of their weight, and they were able to reduce the risk of developing diabetes by 51%, whereas metformin, 31%. And that tells you that diet and activity trumps medication all the time. So there's a big difference. So that's why diet is the best way with activity. And what do? We go to the gym and we take the escalator instead of taking the stairs. Diet. I'm not going to spend a lot of time because it's a long and very complicated subject, but in my opinion, diets, they don't work because if you look online, there are tons of them and we use them for a few months and then we go back to the same habits and if we lose weight, we gain back every weight. So instead of using a diet, just see what the effect of your sugar, if you are diabetic, see if you eat this kind of, or a bowl of pasta, what does it do for your sugar? Next time you eat less, you eat a small amount, spread it about. The main effect of the sugar is the carbohydrate. Fat and protein does not affect the sugar as much. In general, we ask the patient between 40 to 60 grams of carb per meal. If you need to lose weight, you go a little bit lower. If you need to eat or maintain your weight, you keep it the same way. Just to give you an idea, a slice of bread is around 15 grams of carb. And everything we look at has carbs. So it's really hard to achieve a low carb diet nowadays. Always look at your nutritional value here. The total carbohydrate, everything you eat, if you want to try to maintain and keep your weight and your sugar is the same, stick to this 40 to 60 grams. So here we can see how much grams in every of carb in every food. Just to give you an idea from 20 years to now, how our food has changed. Fortunately, I have them in calories. I didn't see them in grams. This is our bagel 20 years ago, and this is now almost triple the calories. You go to the movie theater, the popcorn can feed the whole family. It's almost hard to hold it. Almost triple the calories. Same thing, the Coke. Now we have bigger, more sugar. So we're going to talk a little bit about diabetes medications. For type 2, or in general, most patients for type 2 are on oral medication, some on insulin, some diet, and some are on combination. The medication, we're going to talk about everyone in how they work. They can either affect the pancreas, the liver, the intestine, the muscle, the kidneys. The first class is what we call sulfonylurea. We have old version and newer version, glipizide, glimepiride. The way they work, you can look at it like this. They go and they squeeze your pancreas. They make it produce more insulin. So you take it before food, usually half an hour. Some of them are longer acting. You don't need to take it with food. But because they squeeze your pancreas, produce more insulin. So even if you don't eat, or if you don't eat a lot, your sugar may go down because your insulin is going up. So their side effect, low sugar. And because they increase your insulin, they can make you gain weight. Unfortunately, there's no data that they protect the heart or do anything to prevent heart disease. So there is a step away from those medications, but the advantage, they're not expensive. Meglitinide, another form similar to sulfonylurea, but they're faster acting. There's Brandon and Starlex, the same thing. They go to the pancreas, squeeze it. You take it before you eat, and it can lower the sugar more than what you need if you don't eat enough. And it comes with weight gain. Those are the major side effects. Diet, this is the first line of treatment, metformin. It's what we call insulin sensitizer. So how it works, we really don't know. But it goes to the muscles, makes them produce or use the insulin in a better way, goes to the liver, stops the liver from producing sugar at night, so you can wake up with a better number. You take it, there are different forms. There is an extended release, you can take it once a day. There are the regular one, you take it twice a day. The side effect is GI, diarrhea, bloating. About 5–10% of my patients, they cannot tolerate it, but in general, it's a good medication. It's safe. I had a lot of patients recently come and tell me that they read on the internet, it's bad on the kidney, it causes cancer, dementia, and this is a terrible medication. In my opinion, there is nothing true about that. It's a good medication, safe, old, and it has data that it protects against heart disease if you can tolerate it, and it's generic. Alpha glucosidase inhibitors. This is a brand of medication we don't use a lot. The most common one is acarbose. It's generic. Basically, it goes to the guts and stops you from breaking down the sugar. If you don't break down the sugar, you cannot absorb it. Unfortunately, by doing that, you have a lot of sugar in your gut. You have fermentation of the sugar and you get flatulence, you get gas. So many patients, they don't like it. It can cause a lot of problems. So you don't want to stay in the car with somebody taking this medication with the windows closed. Same thing, you take it with meals, and we spoke about the side effects. TZDs is another brand of medications. We have two, Avandia and Actos. They are also what we call insulin sensitizer. They go and mix your muscles, your fat, use the insulin in a better way, the same thing at the liver. There was a scare about Avandia a few years ago, and it was taken out of the market because they thought it can cause heart disease. But later studies showed no, it's not the case, and the FDA put it more back on the market. Actos, pioglitazone is still there. I use it a lot. It's good medication. It works slowly. The only side effect, it can make you retain fluid and gain water. So if you have congestive heart failure, it's not the best medication, but there are studies showed it can reduce your risk of stroke. And, sorry, if you have a history of bladder cancer, there are earlier report that there are some association with bladder cancer, so that's not the best medication to use. We talked about the side effects. SGLT inhibitor, sodium glucose transporter inhibitor. Those are the new medications on the market. So our kidneys in general, they filter the sugar and they absorb 99% of the sugar. Those medications blocks an enzyme in the kidneys, so you do not reabsorb the sugar. You start urinating the sugar. And because you urinate the sugar, you lose calories in the urine, you lose weight. And studies are very impressive. They are showing that it can reduce your risk of progression of kidney disease, heart attack, stroke. We have 4 of them on the market. Unfortunately, they're expensive, they're brand name. Because you urinate the sugar, you can have tendency, especially in women, to have urinary tract infection, yeast infection, in some instances, severe genital infection. And there are some of them that are associated with high risk of falls, we think because of dehydration and increased fracture. But they're becoming almost the second line or the third line of treatment after metformin. And they can cause, because of frequent urination, you can get dehydrated initially. So you ask the patient to drink a lot of fluid. And if you're going to go to any surgical procedure or you're going to get dehydrated, you have to hold it for a few days because they can have sometimes bad effect on the kidneys on the short term. DPP-4 inhibitors in another class of diabetes medication. We have Januvia, Onglyza, Trajenta, Nesina. Those are not very strong medication. They're not, we don't use them much. They increase your insulin by blocking an enzyme. They're pretty safe. Sometimes you can have some like stuffy nose from them, but in general, they're safe. except on Onglyza. If you have congestive heart failure, you cannot use it. But once again, their effect on the sugar is very minimal, so we really don't use them a lot. The new kid on the block is this class of medication. And like those medication that works on the kidneys, they are the second or the third line of treatment, called GLP receptor agonist. GLP is a protein that we found in the gut normally. After we eat, it increases. When we put it in a pen and we give it to the patient in a higher dose, it works on your brain, makes you less hungry. It slows the stomach, so you don't absorb the sugar quickly. It increases your insulin, so your sugar goes down. And it works on the pancreas by decreasing another hormone called glucagon, which raises your sugar. So it works in a different way. It's not insulin. We have old version Byetta, which was twice a day. Then we have Victoza, which is once a day. And the 3 weekly medication we have are Bydureon, Ozempic, and Trulicity. And there is a newer one. It's in the research. It's not yet out, but the study showed that the weight loss with it is very impressive. And Ozempic now, it's approved for weight loss. And in a higher dose, almost 10% weight loss. But it's a dream to have any insurance cover it. They always deny it. So we spoke about how it works, when to take it, the side effects. This is another amylin. It's another hormone that comes from the pancreas. And that's the only medication approved by the FDA for type 1 diabetes. As we spoke, type 1 is an autoimmune disease. The only thing works is insulin, but amylin is indicated in type 1. Basically works similar to the Victoza-like medication. It increases your insulin, or it decreases your glucagon, sorry. It makes you less hungry. We don't use it a lot because type 1, if they are using injections, they're already using 4 injections, and this medication has to be given an injection before every meal. So giving the patient 7 injections a day, it's not very practical. There are some oral medications that have combined 2 medications. Metformin comes with Actos, Metformin comes with Farxiga, with Jardiance. So there are a lot of medication that can makes it easier for the patient. Instead of taking 3-4 pills, they can take less number. Insulin. Just to give you a historical point, insulin was discovered in Canada in almost 100 years ago. And the 2 doctors, you can see their name, Dr. Banting and Best. And interestingly, that they thought that this is a very good medication for humanity, so they sold the patent for the university for $1. And now we have all those drug companies charging thousands of dollars. It's really sad to say that that time people were more caring about our health. And it's a life-saving medication for type 1. Before this insulin invention, type 1 diabetes, they have a life expectancy of 2 years. You have diabetes, in 2 years you're dead if you have no treatment. Whereas now, people live normal lives. So it's measured in units. It can come in vial. Usually it have 1,000 units. It can come in inhalers. It can come in pens between 300 to 400 units, and some of the new pens even have 900 units. You store them away from heat in a fridge. If you open the insulin, you can use it up to, some of them, 28 days. After that, you have to disregard them. So how our body works, we have insulin all the time. At 4 a.m., healthy people, I'm not eating, I still have insulin because my liver always produces sugar. When I eat 3 meals, the pancreas gives me a boost of insulin to cover this. And that's what we try to imitate. We give the patient a baseline insulin, an insulin that lasts the whole week, the whole day. And that does not help with the meals. And we give the patient a fast-acting insulin that works for those meals. There are different brands. There is rapid-acting insulin that works in 5 to 10 minutes. Those are the most common, Humalog, Novolog. This insulin is an inhaler. It works right away. And those are fast-acting, but not as fast as the above. They take half an hour. And Arizona is one of the states that those insulins, the regular insulin or the N insulin, are over the counter. You do not need a prescription. You can just go into Walmart. They have their own brand. It's called Relion. And just ask them for regular insulin or Novolin N, which is a long-acting insulin. Some states require prescription, but Arizona, you don't need to. So we talked fast-acting insulin, long-acting insulin. Some of them are what we call intermediate. It's at 12 hours. That's why we use it twice a day. And once again, those are over the counter. And ones of them are once a day. Sorry, those are 12 hours. So you use them twice a day. And the Lantus, Levemir, Toujeo, and Tresiba are a true once a day. Mostly Tresiba is once a day. So you just give the injection once a day and you forget about it. You can have mixture of insulin that gives you a fast acting and a short acting. It cut down the amount of injections, makes it easier for the patient, but it limits your ability to adjust your dose, because if you change your dose, you change the two insulin. You cannot play with one. How do we inject? We have different ways: vial, as we spoke, syringes, insulin pen. You just dial the number. If you over dial, you go back and it has a needle, you inject. Vigo is a mechanical device. It's just a reservoir with a spring. You put it on your skin every day. The spring pushes the insulin and gives you the insulin throughout the day. And if you need to give a bolus, there is a click here. You click. For every click, it gives you 2 insulin. So it's not considered a pump because there is no electronic devices with it. Pump, same thing here, a reservoir. It's programmed by giving you insulin through a tube, and there are some tubeless pumps. You change the side, the tubes, every 3 days. It gives you insulin all the time. When you eat, you tell the pump, I ate this amount of carb, my sugar is this, and we program how much. It gives you a bolus for meals. An inhaler insulin, you can just spray it in your mouth and or your nose, and it works like that. So the newer thing for type 1 or type 2 is what we call the semi-closed loop. So we don't have anything close to pancreas right now, but this is the closest we have. A sensor gives wireless information to the pump, gives the patient, the pump, the sugar every 5 minutes. The pump, they have algorithm. If your sugar start going down, it stops the insulin, prevent you from going low. If your sugars start going up, it gives you correction without the patient doing anything. And that's the closest thing we have to a insulin, to the pancreas. We have different types. We have the tandem, sorry, the Medtronic. We have the tandem that works with the Dexcom. We have the Omnipod, which is a tubeless. You just put it on your skin. It has no tubes. And this is what's for the future. It's called the Bionic. It has 2 reservoirs, one for insulin and one for glucagon, which if your sugar start going, it gives you glucagon to raise your sugar. And they claim that you don't need to program anything. You just put it on the patient, put his weight or her weight, and it does everything. It's still in the process of research, but it's not out. But they claim that this will be a game changer. So I think I'm done with this lecture. I have few questions. I don't know if you guys have any questions. Should we go with the questions?
Sure, let's go with questions. If somebody
Okay.
has a question, you can kind of raise your hand and we'll unmute you. I do have a question.
Sure.
We've talked a lot about the pancreas and how that's key in diabetes. Is there a relationship between diabetics or all this activity around the pancreas and pancreatic cancer?
No, I mean, there's no studies or data suggest that if you're diabetic, you have high risk for pancreatic cancer. You can have some pancreatic insufficiency, which can cause diarrhea, but there is no association with cancer.
Okay, that's good news. Thank you. Okay. Do
So
any of our
those,
guests have a question today? Yes, Jim? Yeah, we're going to unmute you, Jim, so that you can ask your question of the doctor.
we still can't hear you.
I'm asking him to unmute. I don't know that. Am I up?
Jim, can you unmute? Are you able to do that? Oh, there. Whoops. We're still not hearing you because,
There we go.
whoops.
Oh,
Oh. I think this is Jim Clark, right? You're wanting to ask a question, Mr. Clark?
Screen. There we
There
go.
you go. Okay, good.
We're good, Ron. All right. Being a type 1 diabetic for over 40 years, I'm interested in a lot of that screen that you gave us earlier about the different types of injectable insulin and what they do and what they don't do. So is it possible for us to get a copy of that?
Sure. I think I have the slides. I sent the slides to, or if you want, if you send me your email, I can send you this. No problem. I
With
don't
your
know, Gina, if you
permission,
can help
Doctor,
us.
yeah, we're happy to send this slide deck to anybody who
Yeah.
might want it. And also we record these and we will send you the link to go to our website and view the information there if you want to go through this presentation again. Both ways.
Sure.
Just let us know. We'll be happy to provide that.
All right, we'll do that after the Q&A.
Yes.
So
Okay, thank you.
you're welcome. Those are just fun facts. You guys are more than welcome to stop me. We have this question: can I cure type 2 diabetes? Can you put yes or no?
Okay.
So I guess Gina is the only, okay. Yes,
If
yes.
you have a paddle, raise it.
Do we all have a panel of the yes or no?
No.
Okay. I don't know how many are seeing yes. Let's see. Okay, it sounds like we have a mix. So the answer for this, oops, sorry, is no, unfortunately.
There we go.
The
All right.
only thing we have, first of all, can you still see my slides?
Yes, we can.
Perfect. The only thing what we have that can cure type 2 diabetes is bariatric surgery, gastric bypass, gastric sleeve. Studies show that initially they can put diabetes, they can cure it and you can be back to normal. Also depending on how bad it is before, but in general, diet, activity, medication can control it, make it close to normal, but there is nothing we have in our hands that can cure diabetes. Does cinnamon has any effect on diabetes? Yes or no?
Yes.
Joyce says yes.
Like we have some yes, some no. Okay, so this is a tricky question. The answer is yes and no. What do I mean by that? Yes, there are studies that show that diabetes can lower the sugar by 10, 20 points, but in a higher dose, like 2000 milligram, if I remember. And we don't know what's the effect of those high doses on the liver. If you sprinkle cinnamon on your yogurt, on your food, it's not going to make a big effect. It makes the food taste fine. So there is no current recommendation from the American Diabetes Association to use cinnamon. So how many tablespoons of sugar are in a can of Coke? I have 4. You can just use 1 or 2. Yes or no? 2 tablespoon or 10 tablespoon? So some people said 10. Let's see, 10, 10, 10. So the majority has 10, which is true. This is 10 of a can. This is more. And imagine this is the big bottle. So whenever you take a can of, I don't think I'm ever took 10 spoons of sugar, put it in a glass and drink it. This is what we're putting in our body. It's amazing when you see the true amount of sugar. This is what's causing our kids to be obese. This is what's causing our economy, our health to go down. If you look at the nutritional value of a can of or Coke, 39 grams of carb, that's one meal. If you drink 1 or 2 a day, which many people, they don't know, and I was one of those long time ago, this is just extra meal, extra 2 meals a day that you put in your belly. Just another visual effect, Snickers. If you go to McDonald's, you see how much, I don't know what kind of shake, maybe Starbucks. Whereas carrot, this amount have 1. So you see the difference. You see what the Mountain Dew, I mean, it's amazing how much sugar they have. This is a disaster to our health. Diabetes is the #1 cause for blindness in the US. True or no, or false? True. True. Sound like we are, most of us are true. That's true. That's why every diabetic, at least once a year, should have a dilated eye exam. It's not only an exam for glasses. The doctor needs to dilate the eyes and look at the back, see there is signs of bleeding. Whether it's an ophthalmologist, whether it's an optometrist, I mean, anybody who can, optometrists sometimes can be very good, and if there is a problem, they can refer you to an eye doctor, ophthalmologist. I use insulin, that means that I have type 1 diabetes. Is that true or false? So if you use insulin, you have type 1. I have 2, true. 1 false, true. So it sounds like we have a mixture. That's a false, because type 2 diabetes, as we spoke, it's a progressive disease. At one point, your pancreas get tired and you need to have insulin. That doesn't mean that you're type 1. But so type 1 and type 2 can be on insulin. Medical cost of diabetes and wages, loss of work and wages, up to 327 billion with a B yearly.
Yes.
That's true. So the impact on our economy, our health, it's amazing. People with diabetes can enjoy their sweets. So you can have sweets. Is that true or false?
Yes.
So we have true, true. So the majority were right. True. I mean, when I tell patients that you need to watch your diet and activity, sometimes people feel like this is a life sentence. That's it. I'm done. I'm not going to enjoy my life. You still need to enjoy your food. If you like a tiramisu, by any means, take it, but smaller portion, less frequently, and see how the effect of the sugar. You still can have almost everything, but moderation. Extra pounds are the only risk for diabetes.
No.
False. False. We have couple false. Most people got it right. That's true. As we spoke, ethnicity, if you're Native American, Pacific Islander, Indian, East Indians, or Latino, by genetic, you're prone to have, or African American, you're prone to have diabetes. Stress can cause you to also have more risk of diabetes. Oh, we just answered this question. Stress has no effect on your blood sugar.
No.
So we did answer this. Stress, whether it's emotional stress, whether it's infection, physical stress can raise your sugar. So that's false. It has effect on the sugar. So I have an A1C of less than 7. That means that I have a good control in diabetes.
Yes.
So it sounds like we have 2 yes. Majority are yes. We have 1 brave soul which said no. So the answer technically is no, and I'll explain why. So those are tracing from sensors for 2 patients. They both have an A1C of 7. The red, you see that his sugar or her sugar goes down to 50s, then go up to 300, and it's zigzagging the whole day. So your average is A1C of 7, but that's not a good control. So A1C is one of the equation, whereas the blue, most of their sugar is in the target range. So if you don't have highs and low, and your A1C is 7, that's where you have good control. That's why there's a new target. Now, on top of the A1C, we aim for something, the target range, the in-range target. The sensor gives you this kind of reports. In the last 2 weeks, it tells you you're 70%, you are in the target range between 72 and 80, and that's our target. Less than 5% low and almost less than 30% high. If you're in that range and have an A1C of 7 or less, that's the target range. But if you're highs all the time and A1C of less than 7, that's not a good control. That's why it's important to check and monitor your sugar. So diabetes mellitus means passing through sweet urine. Let's just use those 2. Pancreatic malfunction, I miss my ice cream. What is the meaning of this word? 1 yes, 2 no. So we have 1 yes, 1 no. Okay, that's just a fun fact. It's a Greek name. Diabetes means passing through. Mellitus is Greek for honey. So in the past, people used to urinate a lot of sweet urine, and I'm glad that I didn't practice that time because physicians used to taste the urine of their patients, and if it's sweet, that's give them the diagnosis. So we came a long way. Just to give you a visual impact, this is an insulin pump when they first invented that in 1970. It's a device bigger than the patient itself. And now we are in this range, and the future is coming. There is a big advantage of being diabetic now. There are new technologies, there's new medications coming in the future. So I think with this, this is my wife and my daughters, and I'm happy to answer any questions.
Oh, beautiful family. Thank you for sharing. My goodness. Are there any questions from those who dialed in today, or do you feel like, I certainly feel like I have a lot more knowledge. Carrie, did you have a question?
Yes, I have a question about carbs. And I think the doctor said 40 to 60 per meal, don't go over. What about things like whole grains? So say you had a whole grain pasta, that's better than white pasta. So do you get to
True.
subtract from the 40 or 60 because you're in the good range? I mean, you're in the good.
You know, whole grains gives you more fibers, give you less amount of absorbing sugar, but I would still think you should stick to the 40 gram, because if you eat more, that will equal to more carbohydrates. So I still always calculate everything to that range to keep you in the target range.
Okay, very good.
So I don't subtract, no, to answer your question.
Okay. No cheating. Okay.
No. Does anybody else? Oh, Gary, you have a question, right? You want to
Yes.
unmute? There you
Yes.
go.
Yes, I do. Can you hear me?
Yes, we can.
Okay, I wanted to know of the popular diets that float around, like the keto diet, the Mediterranean diet, this diet, that diet. Is one of them more, would one of them be more appropriate for handling sugar before?
You know, once again, they all work and they don't work because we don't stick to them. The Mediterranean diet is known to have better effect on cardiovascular risks. It's good for the heart, it's healthy. Keto diet will help the sugar definitely because you're eating less carb, but sometimes you eat less than 10 grams of carb a day, which is hard to achieve. It can put you in risk, especially if you're type 1, can put you in diabetic ketoacidosis. So I'll be careful with type 1, especially, or if you're taking those new medication on the kidneys, the Farxiga, the Jardians, the SGLT inhibitor, because you can go into acidosis without even knowing that. To answer your question, there is no one better than other, no. Anything you can do and stick to it and monitor the effect on the sugar.
Jim Greenwald, you have a question?
Yeah, as my mother used to tell me years ago that the doctor told her that glass of red wine at night was such a good thing for her, and being a type 2 diabetic just barely. I kind of go with my mother.
Yay, Jim.
I agree with her. No, there are some benefits for protection of the heart, especially the red wine. And small amount, has less carb. Bigger amount can affect the sugar, can affect the liver, but small amount is a healthy thing to do.
So 2 glasses gives me even a better heart condition.
Don't push it.
Great question. Thank you. Okay, well, I think you've answered most of our questions. I don't see anybody else that's raising a hand. So our deepest thanks to you, Dr. Hanna Moussa. To put an exclamation point about this great information, there are resources that are really essential to support you in managing or preventing diabetes. And to that point, there are several of Sun Health's community health and wellness programs that are available to all of you as well. We have education on the National Diabetes Prevention Program on October the 7th, Diabetes Connection Support Group October the 18th, the annual Diabetes Self-Management Education on October 28th, and the Nutrition and Medical Nutrition Therapy. So to learn more about these, I'm not sure what the date on that one is, but to learn more about these, you can go to the sunhealthwellness.org website, or you can call. And I was just advised that the Nutrition and Medical Nutrition Therapy is an ongoing program. I encourage you to take advantage. Sure. Yeah. I encourage you to dial into these programs through the Sun Health Wellness Program. So you'll get a lot of information and a lot of support there. How many of you have ever been to any of our wellness programs? There's massage therapy and there's classes and there's diabetes prevention and there's all kinds of education. Hold up your paddle or your hand to let us know if you've been. Great, that's wonderful. Thank you so very much for that. And those programs are supported through the Generosity for Generations campaign. The community funds those programs, so they're available to you at no or low charge. And so continue to take advantage of that. And those of you who have made contributions to support that, we invite you to continue doing that as well. So speaking of the campaign, I'm pleased to let you know that the community has contributed 71% of the $48 million goal of this campaign. Under that umbrella of the campaign, again, we have Sun Health Wellness programs, and then we have projects at Banner Boswell and Banner Del Webb. So support on this campaign continues to be needed, and we invite you to participate at any level that you're able to do that. It's a legacy that was started 50 years ago by these amazing, generous residents who live in the West Valley. And it was then that the Sun Health Foundation's longstanding partnership with the community began, and it's just been robust throughout all of the years and continues to support wellness programs as well as the 2 hospitals in the West Valley. So Sun Health is a trusted resource for you. If you have a question, if you have a problem, if you have a suggestion, we invite you to start with Sun Health. If we are unable to provide the answer immediately, we certainly have wonderful relationships like you heard today with the good doctor and others as well. Just for your own information, we have some events coming up. The Heroes with Heart Gala is on Saturday, November the 6th, scheduled to be held at the Renaissance Glendale Hotel and Spa in Glendale. Support from that event will support the project on Banner-Boswell Medical Center's emergency department and patient care transformation. There's contact information right there for you to register for that event. And our upcoming Coffee with Gina and Friends on October the 1st, Michael Barnes, who is on October 21st, thank you. Michael Barnes, who happens to be on our board of trustees, and he's also vice president of Finemark Wealth Bank and Trust Company, will discuss Is Your Money at Risk? And he will give you 6 takeaways and pillars to keep your money safe. November 18th, estate planning attorney David Eastman will talk about securing your IRA. There are some tax implications and some changes around taxing and philanthropy, especially for non-spouse inheritance of IRAs that are problematic for many people. So we invite you to dial in to hear Mr. Eastman talk about your IRAs. December the 15th, Sharon Lind, who is the CEO of Banner-Boswell and Banner Del Webb, she will be talking about what's new at your community hospitals. And she has an amazing story to tell about the healthcare in this community. And then as we move into 2022, can you believe it? January 20th, Tony Yee, who is Sun Health's Chief Technology and Innovation Officer, will present Protecting Your Identity. It's a huge problem. Identity theft, cyber attacks and all of that's a huge, huge problem. So Joyce will be sending you the information on all of these, and we hope to see you at those events. If you have any questions about today's presentations or previous presentations, remember they are on the Sun Health Foundation website. We have a library. You can go to the link there and review any of the Coffee with Gina and Friends or any other presentations that have been made by our trusted friends and partners in the community. So with that, and in respect of all of your time, we just want to thank you for dialing in today. It was great to see all of you. You're looking very, very well. So please continue to stay well, stay safe, and stay connected. Thank you for joining us. We'll see you soon. Bye-bye.
Bye-bye.
Thank you, Doctor. Wonderful presentation.
You're welcome. Thank you.
Excellent. I learned so much.